Good afternoon, everyone. Thanks for joining us for this afternoon's COVID-19 Provider Education Quickinar. My name is Matt McDonough, and I am with the ESRD National Coordinating Center. On behalf of the NCC, I just want to thank you for joining us today for this Quickinar. These 30-minute Quickinar events are held in partnership with CMS. They feature patient and professional subject matter experts from around the country sharing how they or their organizations are coping with the various situations arising due to the ongoing COVID-19 crisis. Before we begin, I just want to make a note that this call is being recorded, and we'll get this posted to our NCC COVID Quickinar webpage. We say usually within 72 hours, but we've been doing a lot better than that. So please check in with us tomorrow. It should be up there. So let's go ahead and take a look at our agenda for today's call. We're happy to have with us today Jennifer Andersen. She's the clinical nurse educator at Avera McKennan Hospital. She's going to be joining us today to talk about COVID-19 dialysis unit strategies. Now, as our speaker goes through their presentation today, at any time if you have a question, and I mean at any time, please feel free to submit that question using the chat feature on the WebEx or the Q&A panel, which should be in the lower right portion of your screen, or it's accessible from the WebEx menu. When we get to the question and answer section at the end of this presentation, we will share the questions that we received with our speakers. As always, our goal is to answer as many questions as we can as time allows. So it's a little bit about what this call is about. It's our opportunity to hear from stakeholders and peers in the community. We've already talked a little bit about that. The ultimate goal of this series is to share examples and provide some real-world strategies for facilities to use as part of these calls. Hopefully there's something that you'll take away that you can use in your organization as part of these calls. So I'm just going to go ahead and advance to our next slide. And at this time, I'd like to introduce Jennifer Andersen. As I said, she's the clinical nurse educator at Avera McKennan Hospital and University Health Center in Sioux Falls, South Dakota. Jennifer's worked in home dialysis for over 10 years, and now at Avera McKennan Hospital, she's transitioned into quality and education for both the in-center and home dialysis in 2019. Jennifer has an associate's degree from the University of South Dakota in Vermillion, South Dakota, and is working to complete her Bachelor's of Science in Nursing degree in December of this year. Jennifer, welcome.
Thank you. Good to hear from all of you for this evening. I will be presenting on what our in-center unit did to combat COVID when it attacked here. Next slide. So we contributed our success to the following. We actually ended up with 6 total positive cases, and we contained it by doing the following proactive items. We did, on the evening of Wednesday, March 11th, we contacted all patients that were to run on Thursday and did a pre-screen, including those signs and symptoms that had been put out by the CDC. And then on Thursday, March 12th, we contacted all the patients that were to run on Friday and did that same pre-screening. If we did not get a hold of those patients on those evenings or that day, for the following day, we did have a screener at the front door where they came in. Along with the pre-screenings, we implemented the no visitor policy right away. We placed the signs around the unit and positioned an employee at the entrance for screening of those patients that we couldn't reach by phone. During those first runs, we handed out the CDC flyers on the COVID-19, the signs and symptoms, what to do when sick, and the hand washing ones that were provided by the CDC. Next slide. On Friday, March 13th, the staff started screening with temperatures in and out of the unit, along with those signs and symptoms that we were given at that time. We followed the hospital's plan and masked within 6 feet of patients and removed any ancillary staff off of the dialysis floor. So we had health unit coordinators, non-essential staff. We actually moved our supply coordinator out of that area also at this time. We started planning for isolation rooms to be available for known exposures or signs and symptoms that the patients may have. we looked at different options for treatment, and then we decided at that time it would be best to move patients around on our Tuesday, Thursday, Saturday shift to earlier in the time so they were off by 3, so that last shift would be a COVID positive shift. The treatment floors were empty by 3, and then the COVID shift did not start until 3:30 p.m. We had to do some rearranging of which elevators they came up in. We were actually on the 4th floor of our hospital, is where we're located. Next slide. On March 24th, we had our first confirmed case at the local meat packing plant of Smithfield. That kind of became a national news. We became the number 1 hotspot in the nation. So we also have, as it says, this meatpacking plant's health insurance plan is through our hospital. So we knew we would be seeing patients and potential exposures. Even if they were not already on dialysis, the chance of them coming through to us for acutes was brought to our attention. From this day forward, we followed mayors and governors' press conferences that they held daily at around 10:30 in the morning. And then we got a little bit more, I guess, crafty, and we started using social media and the local news outlets coverage for where COVID positive cases were located in our city and counties. Next slide. The social workers worked on updating places of employment for not only the patients, but the family members and their modes of transportation. We also contacted the transportation companies when their drivers had tested positive. We did not wait to hear if one of our patients were on their routes. That proved to be beneficial to us. We actually had 2 drivers of our local transportation bus systems test positive, and we had three or four patients that rode on those routes. And so we isolated them just as a precaution, and that's kind of how we kept things contained. We contacted the nursing homes when they had a positive to follow up on the patients we had in their facilities. So we had a nursing home that had a very large outbreak of both staff and patients. And we did the same thing with these patients. We monitored their symptoms a little bit closer and ran them on that 3rd shift. Next slide. We found that being proactive and having a team that could listen to the press conferences, social medias, and news reports, along with calling the businesses directly instead of waiting for them to call us, helped us to have a head start on the quarantining patients. We did not have any staff members test positive, and that is still to this date. We've had 6 patients test positive. 1 was in our home dialysis patient. Her husband worked for Smithfield. And then we had 5 in-center patients from a variety, from the meatpacking plant to the nursing home. To date, we've tested about 1/2 of the in-center population with 5 positives and 48 negatives. The current patient population is about 103, and I know that we've tested some more since that date and time. Our state has flattened our curve by 75%, so the main county affected opened back up from the social distancing order on May 29th, and we're continuing to do well there. We've seen over 7 days of a decrease in positives. We are continuing to monitor closely after all restrictions are lifted. We haven't seen another outbreak. Next slide. That concludes my slides.
Thank you, Jennifer. We appreciate you sharing that with us. As I'm listening to you go through these, I actually have a few questions that came to my mind, and we've got a couple that have been submitted as well. Before we get into those, I just want to take the opportunity to remind our attendees, if you do have any questions, we are closely watching that chat panel and the Q&A panel. As we start to answer these questions that we've received, please feel free to submit any questions that you might have, and we'll get them over to Jennifer and hopefully get an answer. So Jennifer, the first question I have is, going back to your initial slide. It seems like this response, which seems to be very, very effective, started on March 11th. What was the COVID situation in South Dakota like, or in your specific area like, prior to that? Was there any specific thing that set off the red flags, that rolled this plan into action, or was it just a general response?
It was that general response after that was kind of as they were hitting the nation. And then we were just kind of made aware, to be on the lookout. And that was kind of, we thought if we were proactive and started looking at different options, we'd be better off. That Smithfield was our very first onslaughter of patients, and that came very quickly. And, they had, hundreds and hundreds of positive cases, and we knew we had a significant number of employees from there, either as patients or had family members, so obviously living in the same household.
Mm-hmm.
So we knew that our risks should have been a lot higher, or we should have had a lot more positive results than we did. We're really impressed that we've contained it as well as we did.
Certainly. So I remember seeing the news stories. Like you said, it was a national story. The Johns Hopkins, for those of us who go out to that frequently, that one little section of South Dakota was red, and nobody else was really, really red. So that certainly was a hot spot for cases. Actually, I have a question for you, because I know you're also affiliated with the University Health Center. That's correct?
Yep.
Here in Florida, we're in Tampa. We have a university hospital as well, and it's not just specifically for the school, but it tends to accommodate the needs of the surrounding neighborhoods, and which are mixed demographics and whatnot. Was there any concern aside from the Smithfield part, which is a huge concern, in terms of community impact from the areas that you may serve as part of that hospital?
We didn't. We became the main hub. We did have a few other outbreaks about a month and a half after the big one. We had a couple other communities, like you're saying, that they also have smaller meatpacking plants that were affected, and we did see an influx of patients to the hospital at that time. But we didn't get as many as, like I said, we thought we were going to see. We've got we worried more about those nursing homes. We have quite a few nursing homes that serve quite a few people too.
Kind of related to that Smithfield situation, did you see a lot of Smithfield employees that you served as acute kidney injury patients?
We didn't see very many. We kept prepping for it, but all of our patients seemed to come out of it without needing. We had, I think, 3 that ended up being acute for a few weeks, and that was it.
Okay.
So not nearly the population that other places are seeing with those acute patients.
I have a general, just a geographical type question. Is in terms of the area that the hospital serves, about the radius of that hospital. Was it something where you began using telemedicine to see patients
Yes.
that were spread out more? How did that work for you, especially with the Smithfield situation, which I keep referring to, but there were so many people there.
Right.
How did that go?
It actually went well, as good as it could. We ended up looking at a few different options for doing that. We didn't realize there were as many different telemedicine options out there for software. We're such a rural community out here in the Midwest. Some of our patients drive 4 to 6 hours to get to us.
Wow.
And so the impact of getting telemedicine up and going was important, because we were trying to keep. So the area that the meatpacking plant is in Sioux Falls, which is our biggest community in the state. So we were trying to keep any of those more smaller communities, keeping those patients away from the potential to be to be exposed to it by coming into a clinic or to the clinic or to the center. And so we had to put our heads together a little bit more than probably some of the other places would have to get the ball rolling, but we have been successfully. Our home dialysis patients we have not seen since March. They've all been, all 69 of them have been, their monthly visits have been done by telemed.
Wow. Wow, that's, in 4 to 6 hours, it's kind of hard for us to fathom, and sometimes it's a long way. So telemedicine seems like, the perfect solution for that.
Right.
Really interesting question just came in. Did your facility find yourself ever in jeopardy of not having enough dialysis supplies or the needed supplies to treat the patients? And if so, what was the approach to address any sort of shortage or concern that there might be a shortage?
We were really proactive, obviously with the PPE was the biggest ones. Our gowns, we found a second, our supply chain here in the hospital was very proactive. They knew our needs, so we kind of got put a little bit higher on that hierarchy. When they closed down surgery, we got an influx of what they had in their supply bays. There were a few moments. We did do N95s for a little while, and then they would wear them for, I think it was like the 5 days, and then they would, we actually had the capability to sterilize them here and send them back out. And then our pharmacy went to compounding hand sanitizer for us.
Oh.
So that, but it took a lot. I mean, there was a lot of people involved in trying to make sure that we had enough to get by.
Sure. You noted that on your staff you had no positive cases, which is absolutely wonderful. Did you have any staff members become persons under investigation due to any sort of potential exposure? And if so, how did the facility handle those types of things until those negative results came back?
Well, the base plan for our hospital was that if you had an exposure, a known exposure, that you were to self-quarantine at home for 2 weeks. We, luckily, our staff is pretty good. Nobody wanted to just go home and never, do anything. But they relied on our local grocery store will deliver to the hospital.
Oh.
So we were getting, we kind of are spoiled in some aspects, I guess. The small communities and helping each other out.
Right.
So there was some of that. We didn't have anybody that had even a family member that had been exposed. I know even from personally, between the 5 of us that live in the house, we all work in different areas and arenas that are considered essential. And so there was always that, what if one of us got exposed? But we've sailed through so far, knock on wood. Yeah. You never know when that next round might come, but we've come through pretty good. We thought maybe we'd have a little bit more exposure, but I think people just kind of that social media, the mayor was very, like I said in that one, the mayor and the governor were very proactive about having their daily reports at 10:30. And then I was kind of the gatekeeper on the social medias, our news stations and our newspapers' actual site. And they were very proactive about where an exposure had happened or where an employee had, the different stores or restaurants. Sure. And so we would put it out every day and say, hey, if you had gone there, please, more of that step up and let us know so we can avoid, just that risk.
Right. Transparency. Absolutely. Question related to the social media. Who did the social media reviews for the unit was a question we got.
I did that all. And it started just kind of as curiosity, but I was hearing about, I heard about Smithfield and then turned around and asked the managers and the social workers. I said, did anybody else hear that? And they're like, no. And so I kind of became that gatekeeper where I would keep my, I'd listen to the reviews and then I would, go through the different sites during the day. And then that way we were just, because then the social workers could go ahead and go, okay, well, Smithfield's the easiest example. Okay, well, who all works there? Who has family members that work there? And then, different restaurants, or, if we knew somebody worked someplace that had a positive. Right. We did more investigative work. Usually I passed the information on to the social worker, and then they would reach out to the patient. If they were swamped for some reason, I did reach out to a few patients just to say, hey, did you work on this day? Just to kind of, like I said, just to stay that one step ahead.
Absolutely.
And that seems to have benefited us.
For sure. Did you happen to have any patients that communicated with you through social media? I know you've got a pretty broad geographic population that you're dealing with. That's the funny part. Our population isn't real social media. They really relied on us to tell them, hey, this is where it's being seen. You would get a lot of questions from them, and so it was always good for me to be able to put it out there, and then it gave even our techs something to chit-chat with them, I guess, about. Sure.
That a lot of times that was, and I think that kind of bonded in that stressful situation to keep people from being so stressed out. It was an avenue for talk. Hey, did you hear where the newest one was? Or, any new ones to talk about. So really they relied more on us keeping them in the loop and where to stay away from.
Sure. So you've got a population, and I don't want to say they're not tech savvy, but not their first choice of communications is what it sounds like. Did any of those home patients you have struggle with using the telemedicine platforms? And if so, and they're kind of far away, how do you handle those situations so they could be seen?
We did have a few that we had reached out to the local, your rural hospitals or their rural clinics, and there were a few that went into there and used like one of their conference rooms, or we did find that for our elderly population, which we thought would struggle the most, which of course that seems to be who we have for our population too. A lot of them had iPads, or their family members went out and purchased one for that purpose, for them to be able to be at home. And so it was a little hard, but on the flip side, I think some of those family members were able to take the time and go sit at the house with their parents and help them get linked into it.
No, that's great. That's wonderful. And those iPads are absolutely great for just that. I use telehealth a lot in our family. It sounds like you had things under control pretty much from the start, but was there ever a point where you considered or needed to import any task force staff from other areas to kind of assist your operation?
We did end up, obviously with all the extra precautions and masks and PPE and those kind of things, we wanted our techs and our nurses to be able to focus on their job. And so we did bring in, obviously at the same time, surgeries weren't happening, so that staff was kind of being furloughed. Okay. So the hospital opened up like a Sign Up Genius app where we could list out where we could use extra hands. So we got a few nurses and a few techs that came in and did the extra cleaning, the extra wiping down. The nurses would actually review meds with the patients, giving them still that continuity of care, but knowing that it was taking us extra time to do the normal task. And just the general, we're pretty clean anyways, but just wiping those door handles and being out, we weren't allowing people in the waiting room, but just walking through there and wiping down the elevator buttons. So we did utilize some of that furloughed staff. We gave them the opportunity to pick up hours, helping us out with running labs, doing those extra things.
Sure.
So that our staff could focus on the patients that, needed us. And
right. No, that's it's a win-win for everybody there. So speaking of surgeries and whatnot, has this, at least in your area, has this pandemic slowed down or stopped referrals to home dialysis and or transplants where you are?
Yes, it did. We actually just, maybe a week and a half ago, started putting PD catheters back in. So we've got that, the group that was waiting to start before COVID hit us is now in the works. I think we have 6 or 8 of them scheduled over the next few weeks. So it'll be going pretty good again here in the next few weeks. Mm-hmm. And then our transplant just started requesting spots with our in-center team for runs for patients that are coming from other areas for transplant evals. So all within about the last week and a half, we've started opening back up and doing those elective surgeries such as PD caths and doing transplant evals again.
Great. That's great news. We got one more question, and this one is kind of future or forward-looking, if you will. What are your future plans for your unit's visitor policies? Are you considered doing any sort of phase-in on how visitors may be welcomed back into the facility?
We've kind of debated that. We meet once a week, leaders team of people. We actually have 5 units that are satellite locations out of our main one too. And so we kind of have been in discussion with them and everybody else, just trying to see what we're looking for. Our patients aren't asking, and so we're not really pushing for it quite yet.
Sure.
They haven't even started asking to be able to take off their mask and eat or drink yet. So we're kind of holding our breath, and I mean, we're trying to figure out a phase-in plan, but you just don't know. I mean, how long do you let it go? I mean, like I said, we were kind of basing it off of the city's recommendations, and like I said, we're down to 1 or 2 positives a day instead of our hundreds, and that it's been that steady since about May 29th. Like I said, we've steadily declined. Yesterday, I want to say there were like only 11 total in the state or in this area. And so hopefully we can start looking at some of those type of things and loosen up a little bit more. We're just kind of playing it by ear, I guess. For sure. And then trying to have the backup plan for if we start to see that second surge happen.
Yep, absolutely. Be prepared, because they say there's going to be a second wave, and we want to be ready for it.
And how would we re-implement all of it that we've loosened up on?
Gotcha. One last question just came in, and then we'll move on. Are your transplant evaluations also being done by telemedicine right now?
They were doing a couple of them that way. I think this week was the first week to actually see them in person.
Okay. So we're, like everything else, it's transitioning back into a different format. Well, Jennifer, thank you so much for being with us today. I really enjoyed having a chance to pick your brain on all these questions, and we're really happy that you guys have had so much success at your facility. And it's inspiring, and we appreciate all of the hard work you've done to make that happen. So, and thank you for being here today.
You are sure welcome.
Wonderful. Thanks again. We'll go ahead and move on towards our wrap-up. Before we get there, I just want to tell you about the kidneyhub.org. Many of you have seen this already. We are enhancing this secure, mobile-friendly web tool for patients with new features all the time. In addition to the COVID-19 resources, there are new resources up there linking to the patient grant library, linking to educational videos on linking to high KDPI, suboptimal kidney usage. So we certainly would appreciate you if you would go out there and take a look at that, see if there's something that you find that you like. And if there's something that you see that you're looking for and it's not there, I should say, reach out to us. We'd like to know what you would like to see out at thekidneyhub.org. Our next Quickinar events will be, it's hard to believe we're going to be in July, but it'll be July 1st, 2020 at 5 p.m. Eastern. That's our next patient-focused event. And our next provider-focused event is July 2nd. It's 1 week from today. at 5 p.m. Eastern as well. Now, our patient-focused event next week is going to be a very interesting one. We're going to be joined by a patient who's sharing their experiences having COVID and dealing with all of the things that comes with being somebody who had COVID and kidney disease. So we hope you would join us for that. It's certainly going to be very interesting. On behalf of the NCC, I just want to say thank you for joining us. Our contact information is here. Bottom right, you see our logo. There's kidneycovidinfocenter.com. That is our website for all of our COVID resources, including the registration links for the patient and professional webinars that I had just spoke about, as well as links to the CASER COVID-19 resources as well. So again, thank you so much for joining us. We appreciate your time today, and we certainly hope we'll see you on a future Quickinar event. Have a wonderful afternoon.